It's my great honor to be here in this wonderful meeting. And today's my talk is about managing complex iliac artery disease. Iliac artery disease is a significant cause of peripheral artery disease, and it can present with claudication, ischemic leg pain, and critical limb ischemia. In advanced stages, it may progress to total occlusion, severely compromising blood supply to the lower limbs. Well, according to this task to classification, task A and B regions were preferentially treated with endovascular therapy, but historically, more complex task C and D regions were treated with bypass surgery, but EBT is now increasingly used in this modern era. So ultimately, a treatment decision should always be individualized, considering both the patient comorbidities and the lesion characteristics. Well, these are two major weapons that we have against peripheral arterial disease: balloon angioplasty and stenting. PTI, balloon angioplasty, is usually effective for short stenotic lesion, but it has a high risk of recoil. So stenting is required when residual stenosis is more than 30%, or in cases with significant recoil or dissection, or in long segmental occlusion or CTOs. For stent selection, we have two options: self-expandable stent and balloon expandable stent. So self-expandable stent has a high flexibility, so it's good for tortuous lesion. And balloon expandable stent has a high lateral force, so it's good for ostial or calcified lesions. Let me show you several cases. Here we can see severe stenosis in the left external iliac artery. So we did angioplasty, but the result of the angiogram shows residual stenosis and dissection. So we decided to deploy self-expandable stent here. So this is pre-image, and this is post-image after angioplasty and stent insertion. Here we can see a good flow. Another case with light common arterial stenosis. Here we can see severe stenosis in the right side. So after lesion passage, we deployed balloon expandable stent like this. And we could precisely deploy the stent. And this is pre, and this is post-image with the good flow. This is another case with the common iliac stenosis with the calcification. Here we can see large calcified plaque around aortic bifurcation, and non-contrast CT shows this large plaque causing eccentric luminal narrowing. So I think that we need to deploy some balloon expandable stent with higher lateral force. Also, there might be some possibility of vessel rupture. So we decided to use balloon expandable covered stent. So we inserted two covered stent, and with the kissing technique, we deployed them simultaneously. So this is pre, and this is post-image. And combined CT after covered stent deployment shows luminal gain adjacent to calcified plaque. So covered stents are good for complex lesions because it can provide protection against vessel rupture. Also, it gives better hemodynamic flow with lower resistance risk, but it's more expensive and it's larger in profile. So these findings should be considered when we are choosing the best option for patient. When we plan the procedure, CT angiography is quite important because it can define the occlusion length, calcification, and collateral flow. So also for exercise selection, contralateral crossover technique is the most common. But also we can use ipsilateral approach for short region, or brachial access for bilateral CTO, or flush aortic closures. Here we have light common arterial occlusion. Similar finding on angiogram. We punctured both compound artery. Here we can see some stump here. Stump is very advantageous during crossing because it can provide a clear entry point and it gives better wire support. So it's good to have a stump. Anyway, we advanced Schmidt's catheter and the tip was tightly engaged in the stump, and then advanced guide wire to the other side. And the guide wire was captured with the snare device from ipsilateral common femoral access. And then we pulled down and externalized. Then we can deploy volume expander stand here in this track successfully, like this. Well, Truman versus subinterval passage. Well, Truman crossing is always primary choice for most operators because of low risk of dissection and perforation. But sometimes it's very, very difficult in long occlusion with heavy calcification. Then we can use subinterval crossing as an alternative. So it gives best crossing in long regions. It can bypass heavy calcification, but it has less of extension of subintimal dissection, or sometimes the entry of it is unpredictable. Well, left common ligatory and external ligatory occlusion. Also, we can see stenosis in the right side. So we, on our way to the aortic bifurcation, we performed pre-balloon dilatation in the right side, and then we made a puncture in the contralateral side, ipsilateral side, and we advanced Schmidt's catheter. Here we can see small stump, but anyway, we are going to use that. So the tip was tightly engaged in the iliacal stump, and we advanced the guide wire, but it's in the subintimal space because thermal wire is making a loop. Re-entering at the iliac artery is safer and more controllable because the vessel wall is thinner in the distal part. It can facilitate easier penetration. We always try to avoid aortic re-entry in iliac CTO cases whenever possible to minimize major complications such as aortic dissection. So we are going down, also we are going up from ipsilateral femoral access, and we advanced near catheter and captured the thermal loop from contralateral approach and retracted, pulled down, externalized, and here we performed kissing stand technique with two balloon expandable covered stand. Other part of the external artery was covered by self-expandable stand like this, and post-ballooning was done. And this is pre-image, and this is post-image. Actually, we performed this complex case on live symposium within 1 hour. Well, sometimes we can use outback re-entry device when standard guide wire failed due to subintimal tracking, but officially, the use of outback re-entry device for iliac artery is off-label by the company. Anyway, here we can see complete occlusion in the left side common artery, but we failed in meeting each other, so we advanced the outback device from femoral access and then punctured the Truman, and we could be successful in lesion crossing like this. Well, a very severe case with bilateral common artery and external artery occlusion. So we made triple puncture, dual femoral access plus left brachial access. So after femoral sheath insertion, we are going up bilaterally using Davis catheter and thermal guide wire. Thermal guide was making a loop, so it means that we are in the subintimal space. Sorry. Also, from brachial access, we are going down to the common iliac artery. Here, from the left side first, and then what was advanced wire, and then captured by snare catheter in the left side. So we are successful in left side, making a new track. But we failed in the right side because of lack of support. Because brachial access is too far from aortic bifurcation, so sometimes it cannot give enough support. So we advanced contralateral approach, contralateral catheter, Schmidt's catheter, and then from that we advanced guide wire and it was successful in lesion crossing and kiss extend technique, dilatation with the balloon, and this is pre-image, and this is post-image with the go flow. So endovascular therapy is now gold standard for iliac artery intervention, and a tailored approach is needed for best outcome of our patients. Thank you. Thank you for your attention.